years as a social worker in the rural hospice. And Phil Clark, who is a professor at the University of Rhode Island in the world of gerontology. So it's a pretty august panel, and I'm very appreciative to them for coming. I've been on the phone with them and bothered them for quite a while about this issue as we got off the idea of doing estate planning and how you leave things to your kids. We decided that wasn't what we were going to do. And Joan is going to facilitate. So please, we hope to have this to be a very robust discussion. We want some questions for taking it. I asked panelists to use the microphone and get close to it. You can hear us. We want to make sure everybody can hear us everywhere. So without further ado, I will let Pastor Joan take over. Thank you.
Do you want to say any more in way of introduction, or why you're here, or?
Sure. So I'm here because she asked me to be here. I'm her neighbor, and I have to ask her for favors occasionally. But I do want to redefine some terms. So gerontology is actually the study of the science of aging. I'm a clinician, and I've been in geriatric psychiatry since 1992. It's a subspecialty training in medicine and in psychiatry. It's a fairly new, well, it started in the 1990s as far as, being board certified, et cetera. And I've run several inpatient geriatric psychiatry units, the last one being the one here in Westerly. In fact, I started the unit. But I've also done outpatient. I helped develop the palliative care program at the Providence VA. I worked at the VA for 17 years. So I have sort of an overview of how things play out when people age, both in a healthy way, but in my case, I see most of the time people aging in an unhealthy way.
Thank you. I don't know, Sue.
And I know most of you here. I'm Sue Eldridge, and I am a social worker since I was 25 years old. And I've worked in hospice about 22 years, and I retired 3 years ago. But, and now I work with I volunteer with Westerly Village, which will kind of fit into some of what we say, but if you're interested, there's some brochures there, which is also geared with older people and helping them to have what I could call a better quality of life by being able to remain, or helping them to remain, not the end all, but helping them to remain in their homes at end of life. Okay.
Can people hear me okay?
Yes.
Whenever I talk to older people, I want to be sure they can hear me. So I'm Phil Clark, and I'm the other bookend with Louisa Scobles. So I'm in gerontology, which is the study of normal aging. Geriatrics is really the study of, as she said, health problems related to aging. So they're different, and they are importantly different. So I taught gerontology at URI for many years. And as I get older, I begin to appreciate aging more and more. I want to dispel, first of all, the mantle of expert, which is mentioned on the panel. My mother became more frail about 15 years ago, and I thought I knew everything. And then I started having to take care of my mother, and I discovered I didn't know anything. And I kind of muddled my way through, and I made a lot of mistakes. And I now have a lot of guilt because of things that I did that I regret. So I just want to dispel the idea that you're going to leave today with all the answers. It's just kind of like a support group. So I'm glad to be here to share one perspective.
Thank you. And we have met and came up with like some basic questions that I really would love for them to talk about. But this is also for all of you. So please feel free to raise your hand as we go along, or otherwise I'll just keep asking my questions. And we do have some tangible resources to show you, like toward the end. So, Sandy's going to be my timekeeper, so we're going to cut off that after an hour. So my first question for you all is, why is quality of life, we talk about that a lot, quality of life, resiliency, why is that important, especially when you're talking about the end stages of life? Why is all of that toward the end and also at the very end? Start with that.
So I think it's helpful to define terms. So quality of life is something that actually people struggle to define. And so like in research papers, they talk about differentiating quality of life, which in a lot of ways is a really subjective construct. So it's hard to like measure when you're doing research. The other is your health quality of life, which really is separate, because you can have, you know, health problems but still have good quality of life, and vice versa. All of these concepts are related to the whole idea of healthy aging. What contributes to healthy aging? And these are not overlapping, these are overlapping concepts. They don't really, you know, they're not identical. And so there are lots of research projects that look at that and look at which qualities contribute to healthy aging. You know, some of the most famous studies were done actually at the University of Wisconsin. And a researcher by the name of Carol Riff developed actually a questionnaire. And I'll read through the questionnaire because that might serve as a, you know, starting point for what we're talking about. So she developed a 6-factor model of psychological well-being. The first one was autonomy, that they would measure people on. High scores indicate the respondent is independent and regulates her behavior independent of social pressures. An example statement is, quote, "I have confidence in my opinions, even if they are contrary to the general consensus." This one actually sort of surprised me. Environmental mastery, you feel like you can make effective use of opportunities in your environment, managing affairs, you feel in charge of your life. Personal growth is pretty essential. The respondent continues to develop, is welcoming to new experiences, and recognizes improvement in behavior and self over time. This is also a very important thing, because I think a lot of times people think of older people as being very stuck in their ways and so forth. Positive relationship with others. This is where if you've had trauma or psychological problems earlier in life, you may struggle with this, you know, if you're estranged from your children, etc. High scores reflect the respondent's engagement in meaningful relationships with others that include reciprocal empathy, intimacy, and affection. An example statement for this criteria is, people would describe me as a giving person willing to share my time with others. Purpose in life. This is an issue that comes up no matter what you hear about healthy aging. And high scores reflect the respondent's strong goal orientation, conviction that life holds meaning. Some people wander aimlessly through life, but I am not one of them. And self-acceptance. And this is a concept which you see in all sorts of theories about psychological stages of life. High scores reflect the respondent's positive attitude about his or herself. So like, for example, Erik Erikson, who's a psychologist, talked about the dilemmas at each stage of life, and the last one was integrity versus despair. In other words, acceptance of who you are, being able to look back on your life and be accepting of it, etc.
Well, I covered a lot of things. I think there's some other things that come to my mind when I think of this, and one thing I think is people need to have hope. Whether you're at the very end of life, going to die in the next day, or whether you have many years ahead of you, you need to have things you hope for. And hope changes. What you hope for as a 20-year-old is different than what you hope for as an 80 or 90-year-old, but you still have things you're hoping for. You may be hoping for a good day. You may be hoping to go outside, but we need to remember that everybody needs to have some kind of hope. Hope in God is a big one that you see makes a difference for people. So I just wanted to add that.
Yeah.
And
Well, I agree with the previous panelists, but I just wanted to add one thing, which is, for a lot of older people, quality of life is being able to maintain their health and their ability to do what they want to do. What you would call it functioning, you know, on a daily basis. Can you get out and do what you want to do? And that is a very important factor in some of the studies that we know in terms of wanting people to stay. People want to stay at home, and they want to do the decisions that they want to make on their own. So, and I want to mention also Sue's comment about Meaning in life is very important. Having a sense of direction, spiritual direction. We know that people who are believers in some sort of transcendent God or power have an advantage over those who don't. So having a sense of direction and a reason to get up every morning and do something meaningful in your life. And I know many people here are heavily involved in the church. And so I just want to give a shout out to those people, because without older people, there wouldn't be a church. I think it would be that people who spend a lot of time here are in fact people who give a lot of meaning to this community that we call Dunn's Corners.
Thank you. Yes. Any questions? So the other thing that we also talk about is resiliency, which is different. So can you explain the difference between resiliency at the end of life and what that means for those who are getting older?
So I looked up an official definition, and it basically is an individual's psychological capacity to mobilize their resources and maintain positive mental health when facing unexpected, stressful situations. And the more resilient you are, the more you're able to recover from stressful situations. And I think that, and this is such an important concept because there's actually an interplay between stress levels and biological phenomena that people have linked increased stress, et cetera, to accelerated aging, to changes in your brain, to increased risk of Alzheimer's, to increased risk of disease. So clearly these external factors and social factors do actually impact your biology and can accelerate your aging.
Wow.
Well, I would agree with Louisa that it's really your ability, how you deal with stress or difficult situations, and ability to bounce back, maybe. Even
And how do you build that? Like
how do you build
Yeah.
resiliency?
I can answer that by practicing. So, a lot of older people, especially if we're thinking about end of life, have a lot of experiences in their lives where they have been faced with challenges, and they have found ways of dealing with those challenges, whether they're physical challenges, some health problems, or psychological, emotional challenges with concerns like depression and anxiety. So I think one of the important things about being older is that you have a track record, hopefully, that you can draw on as life increasingly becomes shorter, that you can look back and say, I can see at times in my life when I was able to, oftentimes with my faith, overcome challenges, and you can bring that forward at the end of your life. So it's kind of a paradox that you talk about resilience at the end of life, but it really is by looking back over your life that you can see the times that you really grew through challenges. So resilience is something that everyone, I think, has at the end of their life, but they often don't realize it. And those are the kinds of assets that I think older people need to be valued for. We could call it wisdom, life experience, but certainly it's related to resilience.
So I think I agree with what Dr. Clark is saying, in that there are personal attributes that contribute to resilience, though resilience is also impacted by social policy, by resources in the community, et cetera. So that's where something like the Westerly Village is helpful, because if you're isolated, if you're financially strapped, et cetera, that is going to detract from your ability to be resilient. And these are more social policy issues, and certainly there are all sorts of white papers and so forth that talk about this and how to kind of reduce that contribution to people's resilience in older life.
And one of the things I noticed in my quite a bit of research about resiliency, the number 2 question is, how did your family deal with resilience? How did your family deal with challenges? How did your grandparents start? How did your parents talk about that? And I look back and thought, that's a fascinating question. How did you go through this ever before, or how did you watch your parents or grandparents face hardships? Has a lot to do with where you are.
I agree. And and back to the point before, having meaning and purpose in your life is, I just think, and I hear that over and over again, how essential that is. I have a relative who is 83 years old and will not retire. And his whole purpose is to say, because I will be meaningless. So where do you find that meaning and purpose is so important as it gets to that. And whether it's helping in the church, thanks for that plug, or whatever.
So how many of people here have seen that Netflix documentary, Live to 100, Secrets of the Blue Zones? Okay, so that's a major theme, so this, for people who haven't seen the series, it's actually very interesting, and I recommend you see it. I'm not getting any kickbacks if you do. But it really sort of distills in a very visual form some of what we're talking about. So I guess you would call him a journalist, goes to the 6 identified blue zones around the world. And these are places that are not wealthy. There's a place in Sardinia, a place in Costa Rica, Okinawa, this island in Greece that's very isolated, and Loma Linda in California. And these are places where people tend to live much longer. There's a much higher percentage of centenarians. And he identifies the common factors in terms of diet, but one thing that comes up over and over again is having a purpose in life. Having a reason to get out of bed in the morning is how he puts it. The social support, being accepted by the community and not kind of shunned because you're elderly. They also talk about diet and so on. But faith community, it was also a common theme in all these places.
That's actually also a TED Talk, if you want the short version. If you Google Dan Buettner and TED Talk on Want to Live to be 100, you'll see a summary in about 19 minutes.
How do you spell his last name?
Excuse me?
How do you spell his last name?
Buettner, B-U-E-T-T-N-E-R. And this is based on National Geographic research. Interesting that one of the communities in Loma Linda, California is the Seventh-day Adventists. We're not recommending that you join that church. I think Presbyterians are holding their own. But one of the key things there is life meaning, social support, and the exercise. They go out every Sunday for hikes. So one of the points about resilience is this is all related. So your physical activity, your diet, social support, sense of meaning and purpose in life, as you get older, these become more and more connected.
And I remembered you also saying that it helps with, say I wrote this down, enthusiasm for a treatment program makes it more successful, right? If they go into it having that hope, or at least feeling good about this might have good results. And also physical dependence, being accepting of where you are in life and what the changes are, and then having motivation to just continue and to continue on. So, and if you wanted to talk any more about that, that's sort of, they're all good?
There's a question.
Oh, good. Thank you. Sorry, you're right. I'm going to pass the mic around more. So it is funny because I saw that book sitting there, Being Mortal. I've read it myself. So I want to move into a little different area, and we can always go back and forth, whatever your questions are and all that. But for those who are caretakers, because I used to run a caregivers group, and most of the time I would just open in prayer and just go, because all they needed was support, was someone to walk them through it, because being a caregiver for a spouse or a parent is something we all face in our life. And so are there definitions, because one of the things I asked you all when I was meeting with you was the difference between palliative care and hospice, but also how to get those resources for caring for someone beyond just, there's no one else, it's because there's no doctors, I'm on my own.
Well, I can answer some of that. The caregiving is very hard sometimes when people are caring for somebody that's very sick, as in hospice or maybe with some other life-threatening illness, because that person needs somebody with them all the time, and if you don't have the resources to have home health aides and so forth come, then you aren't able to get out and go to a caregiving group. And I think I know hospice has tried to address this with Zoom caregiving groups, which is better than nothing, but there's something about being together that's good too. But did anybody else want to say that before I go into the hospice? And you might wonder, what is palliative care and what is hospice? Somebody said to me, I thought hospice was palliative care. Well, hospice is palliative care, but for the definition of Medicare and insurance, palliative care is not the same as hospice. Palliative care, you can get as soon as you have a serious illness, you would be eligible for palliative care. But usually it's a precursor to hospice. It's when people are still getting treatment. So say you have a cancer diagnosis and you're still getting treatment to fight the cancer, then you would be eligible for palliative care. And whereas hospice is the doctor has to sign saying they think this is the last 6 months of life. Doesn't mean that you might not be on hospice 2 years later, because as long as hospice can recertify you by showing decline, you can stay on hospice longer than 6 months. But unfortunately, the average length of time on hospice is 18 days. And it's too bad, because what both palliative care and hospice provide is a look at providing quality of life for people that are having some kind of symptoms, usually pain, but it might be shortness of breath, it might be some other symptoms that they're dealing with. And under palliative care, you have a doctor that's a specialist in palliative care. You can have a counselor, a chaplain, the same as in hospice, but they're all separate, and either you pay for those individually or your insurance may pay for them. But each one paid separately. When you're on hospice, it's a different pay schedule, and they also are looking at what I call body, mind, and spirit. Okay? The body is the doctor and the nurse, although everything sort of intertwines in hospice. There's a CNA that would come in and help. It will not be full-time care. If you go on hospice, you're not going to have a CNA in there around the clock. You're going to have someone come in maybe twice a week to help with bathing and those kinds of things. So if you need around the clock or daily care, that's something you'd have to get separate from hospice. They have a chaplain that will come in and pray with the patient and the family. The family is your unit in hospice. They're concerned about everybody in the family, not just the patient. They have a social worker can help with if you need concrete needs, but also counseling, somebody to talk to during that time about what's going on and how it's working out for you. So those are kind of the differences. You can get palliative care earlier on, hospice at the end of life.
I just want to say, there was an article in the New York Times this past year, how, and in the New York Times, and the article basically said, Jimmy Carter, thank you, Jimmy Carter, for giving us awareness of hospice care. It's not just to go a few days and you die, which is what insurance and all those kinds of things say. But he really wanted to be home. He didn't want any more treatment, and it turns out his wife died sooner. So he had hospice in his home, and who would come in, provide services, but then his family, there was no hospital restrictions. Family could come and go, family could be there if they were there. And it was an outstanding article saying, you know, we really need to redefine hospice. And I know insurance would have big argument with me, no doubt, but it's a full range, like you're saying, of services, but the person can be in their own home, on their own, being mortal, on their own schedule, not the schedule of like a hospice or a nursing home. You eat when we tell you, you get up when we tell you. So I just want to share with that because I read that article and it really resonated for me.
Thank you.
Right now, my brother is on hospice, and he is bedbound. He is on liquid foods. He's been on hospice probably 3 months now, and he may be on, it could be here in a year, or he may be gone next week. We don't know. But what that hospice does for them, he can't get out and go to a doctor or to medical care. They bring it to him. The nurse comes in. She works both with the hospice doctor and also with the primary care doctor.
And also there are hospice centers. My father went to one of those because they had a very small house and my parents couldn't keep him at home.
Right.
And and talk about the whole family being included.
Yeah, I just want to say there's a continuum of hospice services. So certainly home-based is sort of the most fluid. That's where, you know, the initial life expectancy is 6 months, but it could be longer. You can get hospice care in a nursing home setting, okay? And that actually provides more staff for the nursing home staff in terms of people keeping track of you, et cetera. And then inpatient hospice, the main one in Rhode Island is located up in Providence, is for people really at the end of life, where your expected life expectancy is 2 weeks and you may need palliative sedation and so forth. I think of palliative care, though, as just a different form of care which emphasizes comfort as opposed, and well-being, as opposed to medical treatment, which is focused on disease and curing disease. So you're still getting treatment, but there's a different focus in terms of looking at your well-being and your comfort.
Thank you. Did you have a question?
How does visiting nurses interact with all this?
Do they have a hospice, the visiting nurse? It just depends. Some home care agencies have hospices and some don't, and then in that case, the hospice would come in when the person was eligible and the home care would go out. I worked for Hope Hospice, which was out of, the south end of it was out of Wakefield, and we did not have visiting nurses in this area, but Hope Health has visiting nurses in the northern part of Rhode Island, I know. So they work together, but it's really when you are ready for hospice, the visiting nurses will go out, not come anymore.
As a rule, the visiting nurses would come from the hospice division of a visiting nurse agency that has hospice services.
Well, it's interesting you're talking about hospice with these cases like your brother or Jimmy Carter. Yeah, the average is 18 days is what a person stays in hospice.
Well, that's why she said Jimmy Carter's example was so important, because it made people realize, oh, I don't go on hospice and die tomorrow. Although it's happening frequently because people wait till the end. And that's a whole nother, could do a whole session on why people are afraid of hospice.
Right,
Yeah.
so some who are going into, some don't want to go
you know, obviously I knew well for years and years, and he had end-stage prostate cancer, and he was living in Florida, and at some point, his friend called and said, he can't be down here, he can't even get out of a chair, you know, he can't be living in his apartment, his condo. So we brought him up to New York, where we lived, out in the country, outside New York, but it was very woodsy and isolated, and he hated it. He was isolated. All the things we talked about, quality of life. He had nothing to do but wait for me to come home from work and play cards with him. We did have, I think he had some PT come in, and he went in and out of the hospital 5 times from beginning of August through December, and he begged to go home to Florida. And so we said, if you can get strong enough to get on a plane, I'll go with you, and if you're willing to get hospice in there, because then you'll have medical care coming and seeing what's going on as well as the rest of hospice. And if you'll get a caregiver in there, you can go home. And he did.
I think American medicine in general is way too focused on curing, treating, et cetera. And I think the reason why attitudes towards hospice at a social healthcare policy have sort of loosened, because it used to be that you were allowed 6 months, and if you didn't die in 6 months, that was fraud. And they've obviously loosened up the criteria, is of this recognition that some incredible percentage of the Medicare budget is actually spent on fetal care in the last month of life. And I think that, because people just want to just avoid the idea that they're dying. So I think that contributes to the reason why people are only on hospice for 18 days, because they're busy getting this care, which really is not going to prolong either their quality or even their length of stay. In fact, there was a famous article a few years ago from the New England Journal where they actually compared people on hospice to people who were just getting care as usual. The people on hospice actually lived longer than the people who were getting care as usual.
I heard that.
Yeah, we have
Well, one person commented, why aren't there more geriatricians who take care of older people? And partly, like Louisa said, it's because older people are not going to get better, but they can be managed and they can be treated, and their quality of their life can be maintained. Rhode Island is about to become a super aging state. So it doesn't mean that every older person will have a cape with S on it. But what it does mean is that we'll have 20% of our population will be older people, 65 and older. So we really need to find a lot more geriatricians who want to work with older people and for whom this is really a calling. The other reason that you don't see a lot of geriatricians is they don't get the high salaries that people in specialty areas get. So it's kind of going back to the issue of, if you're living in a healthcare system that's making profit, then the incentive for people to work in this area is reduced. So if we could ask everybody here to go out and lobby for more geriatricians, that would be a great outcome.
We have a question over here too.
Just more a comment. My father-in-law was actually on hospice care for probably close to 2 years. He just kept going. But he did have physical therapists come in. He had nurses come in, a lot of contact with the family. We lived for the last 10 months maybe. We lived on and off with him. But he even had like therapy dog come in, which was wonderful. So there are definitely, I mean, I live in Connecticut, so I don't know if that's different, but it was really, really a wonderful experience. I can't say enough good things about hospice. So.
We need to dispel the myths, yes.
How do you establish hospice? Like, how do you apply for it, who does that? Family or?
The doctor, right?
Anybody can call hospice. Your doctor, usually the doctor will say, maybe you should consider. But, if you feel someone is ready for not getting any treatment any further, and would benefit from it, then you call the hospice and say, because when you call, then they're gonna have to come out and evaluate whether.
So hospice actually, so I could call as a layperson, don't have to be a
Yes,
doctor.
you don't have to have your doctor, but your doctor's gonna have to sign off on
Yeah,
it.
right, the doctor
Doc
has to sign off.
Right, so if your doctor's against it, that's not, you're gonna either need to find a different doctor or,
Yeah, did you have a
Paul.
question? Oh, yeah, no, question, yeah. And there's one behind you too.
I'm sort of changing the topic a little, but Sue, you bring up a good point talking about your relative. How much do you allow that person that you have responsibility for to make the decisions? And when you see them making the decisions that you feel are not going to be healthy, what do you do?
well, that's a difficult question, but I always said, as long as a person is mentally competent, they have the right to make whatever decision they want to make. And it may be a really bad one, and not every doctor would agree with me, but, that's their choice, not anybody else's, as long as they know what they're choosing.
I have a, sorry, I'll go back in I have a good friend who was the pastor at the Wilton Presbyterian Church in Wilton, Connecticut for years. And she's wrote a book, I'll show it to you at the end, called Invisible Conversations with Their Aging Parents. And it basically is, how do you approach some of these questions with, especially, she talks about parents mostly, but so that you have an understanding of what, and then we both have this resource called 5 Wishes, which is all about what you wish. When you're competent, fill this out. What do I want? And because one of the things that I have seen over and over again is when people care for someone and they pass away and they have all these questions, shoulda, woulda, coulda. Should I have done this? Maybe I couldn't have done this. I don't know if this was their wishes, when they were unable to communicate what they wanted. So it's like, do it now, and have those difficult conversations so that you know you're doing what they wanted as much as possible. So anyway, wait, there's another question back here.
In the 5 wishes, it says, who's eligible to fill this out? And they said, if you're 18 years old, you can fill this out, or older. And it's more than just advanced directives include the durable power of attorney for healthcare and MOS form, which is like DNR and what you want when you're dying. Those are 2 different ones. This includes things like that, but it also includes, it goes beyond that, like what are you hoping for at the end of life, or are there things you regret and want to say ask forgiveness for, and that kind of thing.
And also, like, I want to be home no matter what.
How many
Make it
people
possible.
here have filled out advanced directives in this audience? So maybe half, right? And I have to say that was one of the most frustrating parts of my dealing with patients, is that they didn't want to think about it, right? And unfortunately, this leads to these situations where either families are pushing for aggressive care when clearly it's not in the patient's benefit because they just can't let go, or the patient may be denying care, which maybe would benefit them, what would they have wanted when they were competent, et cetera. And it can lead to some really thorny issues. I'm actually working on a symposium right now for the AGP that deals with hospice care and dementia. And I think that the durable power of attorney as written is kind of vague, like if I'm in a terminal condition, whatever that means, et cetera. And really it needs to be much more specific about, if this happens, what would you want, et cetera. The reality is that people can still change their mind about what they want, but at least it's a starting point.
I always say there's nothing in stone. You can always redo those papers.
Right. Yeah. I'll go back here.
As far as the villages, I'm wondering, would you do something like that? Go into somebody's home and talk about these things?
Would I do that?
Yeah, would that be
As a
something?
church member? you
As
mean?
a village person, as a village's person.
I haven't done that as part of the Westerly Village. my role's a little different there, but,
It's usually a lawyer thing, but
well, it could be a lawyer, it doesn't have to be. The durable power attorney, all it requires is two signatures that are not your family, not your medical people providing medical care to you. So if you're in a nursing home, not anybody there, or if I come in to see you as a hospice social worker, I can't sign that. But your two neighbors could come in and sign it, and it would be legal.
yeah, so the easiest thing is when you go see a lawyer about your will or getting a power of attorney, that's the time to, you know, they usually can provide that option of filling out that paperwork. And then they have the signatures and the notary and all those other things.
There was a question.
My thought was sometimes some of you know things that the lawyer doesn't know that are helpful.
Mm. Mhm.
I could if you, it's possible.
I think there's one very important topic, it's denial, both by the patients and the families, and we have numerous friends who have waited way too long to consider that they might need help. And now they can't find the appropriate help or have to go into a much more comprehensive care than they really wanted. And so, you know, I saw this a little bit with my, you know, my own father, who ended up coming to move into a nursing facility near where I lived the last 2 months of his life. But I mean, I had to convince him to sign a do not resuscitate order. I mean, he was almost 90, and I had to sort of say, it will break your ribs. You will be in utter pain if you have CPR or whatever it is. And yet at the same time, I also had to fend off family who had wanted everything done possible. Yet it then became clear my father was ready to let go. And, you know, to be able to say, you know, that's his wish. And within 3 days, he was gone. And but denial is, I think, a really big thing, and I wish society as a whole would talk more. I certainly talk to my son about what I want in the future. And I don't know exactly what I want, but everybody's talking about staying at home. But I'm saying I'm also looking at group living not at home, because the isolation and the problems that comes with family being so far away is an issue.
And the burden put on the family to keep you there too is hard too. I was also going to talk about the person that it's really important to try to choose the right person to be your power of attorney and your what's healthcare advocate proxy, because so we just went through this with my mother a year ago, and there's 4 of us sisters, and it was so important that my one sister was chosen because we all respected her decisions and we all made them together. But at the end of the day, we knew that she chose the right person. And so choosing the right person that you know knows what you want, but then also can get along with everyone else in the family.
I have 2 questions. One is, can we get copies of the, particularly the 5 wishes, the 5?
This you can get on, go
Amazon.
online and they'll.
Amazon,
you can
$10.
get them.
Okay.
I don't have extra copies, you can look at it, but you just get it offline.
Okay, I guess the next thing is how do you start those uncomfortable conversations? We're dealing with this with my husband's elderly parents, and on good weeks and good times, they don't want to talk about this at all because things are going great. But on bad times, they don't want to talk about it because we're being negative, and how can we even think of that? So we're dealing with some really serious issues, and they don't want to talk about it.
But they're also on different spectrums, because one feeds on socialization through the other one, and then as far as practical things, it's the reverse. So.
Well, neither one was unable to live by themselves when one of them goes, because my father-in-law will be totally socially isolated, although he could probably manage alone. She can't find her way out of a paper bag, so she's very social, but functionally she couldn't live alone. So we've got both, but again, we can't even start those awkward conversations because, and they're in their late 80s, early 90s, and they still won't even think about these things, and it's
So-
going to be a mess.
So here we're going to circle back to the lack of geriatricians in the world who are more attuned to these issues. And I think that in the old days, you couldn't even get reimbursed for doing an annual physical by Medicare because it was so treatment problem focused. However, a few years ago, they did allow for being able to bill for counseling like this. And in a perfect world, your primary care doctor would be a key person to try to initiate a conversation like that. So depending on the primary care doctor, you might be able to enlist their help to initiate that conversation.
I just want to add to what these two other women said, because I'm a therapist and I'm working with somebody who I've known a while. His parents are elderly, live in Pennsylvania, have, to your point, they're not socially connected. They chose not to be. They moved to Pennsylvania to be near a daughter who had children who have nothing to do with them. And he, over the years, has said, we really need to have the conversation. What do you want if anything happens? Where do you want to be buried? Where do you want to live? And to your point, they did not want to talk about it until the father, who had been having symptoms, finally went to the doctor and, oh, by the way, found out he's got late-stage cancer. And then was seriously ill in the hospital. And then what do we do? And I said, you know, hospice is going to be something that maybe he's going to need. And so they finally had a little bit of a conversation. Yes, he said, I want to go home. And, but my client said it was so hard. Over the years, he kept saying, please, let's talk about these things. I want to do the right thing for you. But they just would not, to your point here, both of these would not do it. And he ultimately did go home and really, the cancer had spread everywhere, because I'm guessing he probably had symptoms a long time, but who knows. And he did die at home with hospice. But the son was just so, it was so hard for him because he really was trying to help do the right thing. So
Yeah.
communication with the family is key. Even going to the prime care to say, hey, here's what's going on with my parents. Can we sort of have a meeting with you, with us, and see if we can get any movement at all? It's hard.
And that's another point too, is the, when they basically don't tell their doctor things.
Right.
Right?
Don't tell them the truth.
Right. I'm fine. Mhm.
But you can always say that he made his choice by making no choice. I mean,
Did you have one?
What if you have a person who doesn't have a doctor and hasn't had a doctor for many, many years and refuses to have a doctor? How would you work about hospice or anything like that? They absolutely refuse to even go to the doctor. So periodically we would get a patient like that, and usually you have to wait for them to crash and burn and end up in the hospital, and then you just have to deal with the pieces.
Okay. Well, that was, and the next thing on my list is supportive care. Like, how do you find the resources? How do you get the support you need? Yeah, do you have a question?
There's a wonderful new program in Charlestown, and I don't know if anyone's familiar with it, but through the ambulance, someone comes out and visits an older man in my neighborhood once a week and checks on him. They just got a grant for it very recently, and they're willing to help with whatever. So the guy said he needed rubber gloves, and she got him a box of rubber gloves, but she's also willing, the young ambulance person is willing to, you know, find other resources and do anything. I don't know the name of it or anything, but you can call the Charlestown ambulance or the Charlestown police, and it's great because this guy is home and he's been on hospice, but he got kicked off hospice.
He graduated.
He graduated, yeah. But now this program is wonderful because he's not able to go out to the doctor. So they, you know, check his blood pressure and talk to him and stuff like that. And it's helping the wife as well, of course. So it's a great program.
And I'll bet there are a lot of resources out there that people just don't even know that are out there. So, what else? Yes?
I'm thinking about resiliency,
Mm-hmm.
because I'm already old. I'm not getting old, I am old. And I have people right here who help get around, keep me in circulation. Jan and Stacy and Judy and Pam. And I don't know who else is back there. But anyway, without them, and my family, I would be at home because I don't drive. I'm very well able to take care of myself. You know, I mean, what do you do? Eat, exercise, whatever.
You do all that, yeah.
But I have a puzzle mind. And that, I know what to do when I'm getting up in the morning. That's not a problem. But what am I meant to be doing besides taking care of myself so somebody else doesn't have to do it? There must be something else I should be doing.
You're walking more than I do. I see you walking down the street. You know what? I gotta do it. If Joyce is walking, I gotta walk.
But and there's another point that you made, which is you accept the state that you are in, so therefore you accept the help. And so I know that those people that help you love helping you because it gets you out and right?
We had this discussion once, excuse my voice, one day in the car, and she said, "What is my purpose at this age?" And I said, "You make me smile. You've got family that absolutely loves you. They come and cook for you if you want. You make us happy. You make us know how to live." She's walking
And-
twice a day. I have a picture on my phone. She was out in the pouring rain the other day in a raincoat that was 10 times too big for her. She's precious, but she makes us smile, and she makes me want to get out.
And there's a purpose right there. There's a
I better not turn into a salad bowl.
right. But because I visit a few people that they will not accept help from others, and they are homebound, and they never leave their home,
And I call them.
and they're sad.
If they don't offer, I call them.
But they say, you know, just for the record, social isolation is as bad as secondhand smoke. And we've all freaked out about that, right? Very few people smoke, and we don't let people smoke around grandkids, all that kind of stuff. So social isolation, I just can't believe it's equivalent in terms of its death.
I just want to differentiate social isolation from loneliness. And it's loneliness
Okay.
that is the toxic
Okay.
derivative of social isolation. Not everyone socially isolated necessarily minds it, right? But loneliness actually has been identified by the Surgeon General as being an epidemic in this country and having concrete physical consequences, again, with impact on your biology, premature aging, and so forth.
You're right, there's a difference. So, Laurie, would you?
Oh, good. But go ahead if you want to say something.
I just want to say, Joyce, your purpose in life is to be a poster child for successful aging.
Hi, I see some of my fellow Westerly villagers here. Great to see you guys here. I'm Laurie Meisner, I'm chair of the Westerly Village. And the only reason I wanted to stand up right now is because to respond to your comment just now, is it Joyce?
Joyce.
Joyce. A lot of our members have the same question. They don't necessarily want volunteers to do something for them, although they could use the help or the ride or whatever. But they're saying, what can I do to give back? And we do have teams of people who visit others who can't get out, or who are lonely, or who need some company. And that is a great benefit to them and to the person giving that of themselves. So some of our volunteers and some of our members cross over to be able to, do that. And if you don't drive, but you were to join us, somebody could drive you to the person's house so you could have that friendship visit, we call it. So, just a word.
Nice. Yeah.
You know what, there was also, I'm always reading a lot, but there was a great article on people mixing of people in a nursing home, but also, and there's a daycare center attached to it. And the video of these children along with the elderly, whether it's movement or dancing, whatever. So in terms of your purpose, you may want to think about if you care about kids, and I don't mean that in any kind of judging way, what could I do to get involved in the community with a different generation? Well, how could I serve? I know my daughter's little guy is now in nursery school, so there's once a week that somebody can come in and read to the kids, whether it's a parent or a grandparent. she was still driving, but she loved being a worker for Meals on Wheels. So she was late 70s, but loved going and sharing, making sure, and it's also kind of a well check, if you will. But that may be another way to find a purpose with a different generation, whether it's through a school, whether it's through a church, whether, but many elderly, my mom included, like to be included in multi-generational kinds of things, which is a lot in Weekapaug. There's lots of generations of family that you see each summer. So that may be where you can find some purpose.
Thank you. And we are almost out of time, so I want to make sure if you have something you really want to say too. And I know something. Don't worry.
Pick me. I wanted to just quickly ask about memory loss, how you know what's normal.
Oh, and it actually was one topic that we talked about.
Hopefully I'll remember the answer.
I want to say that this is a serious question.
I know why Rachel was so eager, because she was worried she would forget to ask it.
But it's true, we chose not to focus completely on dementia and some of those major issues, just because that's a whole nother panel. But
So the official recommendation is at annual physicals that you not routinely screen for memory unless there are certain symptoms. And the Alzheimer's Association has, I forget, there's the 6 or 8, worrisome symptoms you want to look for, such as getting lost driving and so forth. And at that point, you can do a memory screen and see what the person's, either baseline or possibly deficits are. But if you look on the Alzheimer's Association page, they do go through what would be considered red flags. There are normal changes with memory as you age. Like, for example, it does take a little bit longer to retrieve your memories, right? You remember it, like, oh, what was their name? And then, in the middle of the night when you're getting up to use the bathroom, oh yeah, that's their name. So that, to some degree, is normal, but there are specific behavioral things that you do look for, so.
We can do that maybe another rainy day.
yeah, right. Yeah.
One thing I would like to stress is the caregiver. Too many caregivers try to do it alone, and from experience, you can't do it. You've got to have help. I can name two examples where people tried to do it alone, and they didn't make it. The caregiver dies before the patient. You need help.
Yeah.
Yeah, that's a caregiver stress.
Yep.
We always say the caregiver has to take care of themselves first to be able to take care of the patient.
Yeah, the analogy I give when I'm trying to convince people that they shouldn't do it alone is, if you're on an airplane and the oxygen goes out, you have to put the oxygen on you first in order to be able to take care of the person next to you.
Right. Are we done?
Questions? We're good?
I want to say thank you so much to our panel. And I'll leave this book up here too. It's, as I said, it's from my pastor friend. And the 5 wishes.